Number 1. Signs of improvement in paranoid schizophrenia are best seen when the client begins to talk openly about their feelings, like saying, "I feel anxious." That ability to verbalize emotions is the clearest indicator of progress. Guarding possessions still reflects paranoia. Punching a bag may release anger, but it isn't evidence of psychiatric healing. And being punctual is nice, but it doesn't prove treatment success. Number 2. Depression shows itself most clearly through hopelessness and negative self-worth. Those two together are the most diagnostic. Weight loss can be from many causes and isn't specific. Saying everyone is out to get me is paranoia, not depression. And keeping things to oneself fits better with a paranoid personality pattern. Number 3. Substance withdrawal follows recognizable patterns. With alcohol withdrawal, you'll see restlessness, confusion, a fast heart rate and breathing, sweating, and then risk of hallucinations, paranoia, and seizures. Opiate withdrawal looks like the flu: watery eyes, abdominal cramping, and body aches. Cocaine withdrawal, on the other hand, causes depression, fatigue, and slowing of movement. Number 4. After a diazepam overdose, the nurse should focus on helping the client identify personal strengths to rebuild self-esteem. Avoid asking why questions, which sound judgmental, and don't dwell on self-critical statements during crisis stabilization. Number 5. When a child has injuries that look like abuse, safety is always the top priority. Respecting cultural practices comes second. Parents expressing regret or talking about burn care are not as urgent as protecting the child from further harm. Number 6. If you're assigning a roommate for a depressed client, the best option is someone who is manic but has already started lithium and is stabilizing. Avoid pairing them with someone who is suicidal, severely depressed, acutely manic, or paranoid, because that combination could increase risk. Number 7. If a client says, "My tongue is rubber, I can't eat," that's a delusion. The best intervention is to offer a balanced liquid diet so they get nutrition without confrontation. Don't argue with the delusion. Prepackaged food helps paranoia about poisoning, but that's not the issue here. And TPN is invasive and not a first-line response. Number 8. When discharging a client with depression, the most reliable indicator of improvement is when the client states that their mood is better. Sitting with others could happen even if symptoms remain. Awakening easily could just be from medications, not recovery. Number 9. If a client on constant observation asks to smoke, the first step is to reassess whether constant observation is still needed. Explaining rules without reassessment may increase agitation. Nicotine patches or support groups are long-term supports, not immediate actions. Number 10. For schizophrenia with command hallucinations, hospitalization is necessary if the client cannot resist voices directing dangerous acts. Voices do get louder when clients stop medication, and coping strategies may include taking extra prescribed medication or telling the voices to stop. Number 11. Building trust with paranoid or psychotic clients starts small. Greet them by name, keep contacts brief but frequent, and build rapport before suggesting social skills training or group activities. Number 12. If a burn client expresses suicidal thoughts, the best response is empathy. This must feel unbearable and we want to help. Never argue, scold, or offer false reassurance. A chaplain may be supportive later, but first, meet the client where they are. Number 13. Sublimation is a healthy defense mechanism. It's when a person redirects unacceptable impulses into something constructive, like boxing instead of aggression. Regression is going backward to earlier behaviors like bedwetting. Displacement is taking anger out on a safer target, like kicking the dog. Undoing is trying to cancel guilt with a compensatory act. Number 14. When a client says my food is poisoned, don't argue. The best action is to leave the tray nearby and stay supportive. Avoid why questions and don't give false reassurance. Number 15. The hallmark sign of depression is a negative self-image. Grandiosity signals mania. Suspicion signals paranoia. And suicidal thoughts may be present, but they are not the defining hallmark. Number 16. Identification is when someone imitates traits of a person they admire or fear. Sublimation is channeling impulses into acceptable outlets. Introjection is internalizing the values of others. Repression is unconsciously blocking painful material. Number 17. When a hopeless client says, my problems are too big, The best response is to invite them to share more. How can I help you? Tell me more about what's going on. Don't minimize, deny, or offer false reassurance. Number 18. If a client says, I used to believe I was Jesus, the nurse should normalize the experience. Other people have had similar thoughts during stress. Avoid belittling, judging, or asking why. Number 19. If a manic client insults the nurse, redirect them into a structured activity such as playing cards. Only if behavior escalates into a safety issue should you isolate or medicate. Don't argue or threaten. Number 20. A child with green vaginal discharge is a red flag for sexual abuse. Gonorrhea in children is considered abuse until proven otherwise. Always report immediately. Number 21. Delusions are hallmarks of psychotic disorders like schizophrenia or schizoaffective disorder. They are rare in anxiety, personality, or dissociative disorders. Number 22. When a child shows injuries and you suspect abuse, use an open, non-judgmental approach like, tell me more about what happened. Sarcasm or dismissive comments are harmful. Reporting is mandatory after your initial assessment. Number 23. Neuroleptic malignant syndrome is a medical emergency. Watch for very high fever, muscle rigidity, unstable blood pressure, fast heart rate, and altered consciousness. Take vitals, notify the provider immediately, and prepare for ICU-level care. Number 24. Legally, nurses must report suspected child abuse right away. Do not wait for test results or confirmation. Document what you see, but only after you've made the report. Number 25. Teaching for flufenazine decanoate, a long-acting antipsychotic, includes avoid sun exposure because of photosensitivity, avoid alcohol because of sedation, report sore throat or flu-like symptoms because of a granulocytosis risk, and continue benztropine daily to prevent extrapyramidal side effects. Number 26. Lithium carbonate has a very narrow therapeutic range, so you need to recognize early signs of toxicity. Early toxicity happens when the level is under 2.0 and shows up as diarrhea, vomiting, drowsiness, and muscle weakness. As the level rises, you'll see ataxia, tinnitus, blurred vision, and large amounts of dilute urine. The right nursing action is to hold the next dose and notify the provider. Do not stop the medication forever on your own, and never force fluids without a specific order. Number 27. If a defensive parent in the emergency room starts accusing the nurse in an abuse situation, what you're really seeing is projection. That means she's putting her own unacceptable feelings onto you. It is not regression, which is acting immature, not sublimation, which is redirecting impulses, and not suppression, which is consciously pushing thoughts away. Number 28. ICU psychosis, or acute confusion in critical care, is usually triggered by overstimulation, lights, alarms, lack of sleep. The best nursing action is to cluster care so the patient gets real periods of rest. You can't just strip the ICU of equipment, and teaching is ineffective when the patient is confused. Number 29. If a paranoid client insists their things are being stolen, don't argue or lock things up. The best approach is to redirect them into a positive, structured activity like exercise. Ignoring them lowers self-esteem, and arguing only feeds the paranoia. Number 30. Delusions of poisoning often come from deep mistrust and low self-esteem. The nursing goal is to build trust and help support the client's self-image. Encourage simple, non-competitive, low-concentration activities where they can succeed. Number 31. If a paranoid client tries to leave saying, "The secret police are after me," the best response is a supportive presence. Come with me to your room, and I'll sit with you. Don't challenge the delusion, don't offer false reassurance, and don't tell them how they should feel. Number 32. Retirement-linked depression often comes with guilt. The nursing goal is to increase awareness of guilt feelings so they can be processed. Don't just say it's about adjusting to retirement, because guilt is the root, and you don't need to wait for the team's approval to start working on this goal. Number 33. Again with depression and guilt. The key nursing action is helping the client identify and explore guilt, not dismissing it. Number 34. Clients in acute mania need structure. Provide a quiet environment with minimal stimulation. Schedule solitary non-competitive activities, and supervise decisions because they're impulsive. Avoid large groups or complex activities that can frustrate or overstimulate them. Number 35. In group therapy, if an older adult monopolizes the session, remember what phase you're in. In the working phase, members should confront and manage this themselves. The leader shouldn't hold private side meetings, give direct orders, or ignore the problem. Number 36. When a new group member defers all responsibility to the leader should clarify their role and redirect the responsibility. What would you like to accomplish? Don't bargain, distract with facts, or overanalyze feelings right away. Number 37. If a client is overwhelmed and anxious, the best response is to ask what coping strategies have worked for them in the past. That builds on their strengths and self-efficacy. Avoid just repeating back their problem or handing out advice. Number 38. Early in rehabilitation, when a client says, "I'll do anything to get out," what you're hearing is manipulation. At this stage, true insight isn't realistic. They may use defense mechanisms, but manipulation is the most accurate label. Number 39. Cocaine withdrawal looks like depression and slowing down. Expect fatigue, low mood, and psychomotor slowing. If you see restlessness, hyperactivity, or hallucinations, that's intoxication, not withdrawal. Number 40. If a client is mumbling and responding to auditory hallucinations, the first action is to ask how they've managed the voices in the past. That promotes coping. Exploring feelings or instilling hope comes later, but first build on their strategies. Number 41. With atypical antipsychotics, the number one teaching point is weight gain. Encourage a healthy diet and exercise. EPS are less common than with typical antipsychotics, but can still happen. Salt intake is specific to lithium, not here. Number 42. If a client has fixed delusions about the FBI, the only treatment that works is antipsychotic medication. Anxiolytics just ease anxiety, mood stabilizers address mood swings, and sedative hypnotics only help with sleep. Number 43. Valproic acid requires monitoring liver function tests because of the risk of hepatotoxicity. Lithium requires kidney checks, not liver. CBC and chem panels are routine, but liver tests are the priority. Number 44. During a PTSD flashback triggered in group, the best action is to reassure the client of reality and move them to a quiet, low-stimulation setting. Don't confront the other client, don't dismiss the group, and don't medicate immediately unless it's truly needed. Number 45. If a client just discharged for suicidality and alcohol abuse comes back lethargic and irritable, your first question is, how much alcohol are you drinking daily? Sobriety must be established before any other treatment plan can work. Number 46. In a residential program, if a bipolar client exposes themselves, redirect that energy into something physical and demanding, like a workout or chores. A one-on-one discussion is ineffective during manic behavior, and restricting social contact just increases agitation. Number 47. If a Jewish client with depression is asked, "Have you been saved?" that's inappropriate. The correct response is to support them within their faith, offer to involve a rabbi, or explore how faith has helped them in the past. Respect their beliefs. Number 48. After an overdose, the most urgent assessment is safety. Do you still feel like harming yourself? The details about pills or regret come later. First, confirm intent. Number 49. In a suicide treatment plan, the most reassuring sign of progress is a written no-harm contract. Written agreements are stronger than verbal promises, family discussions, or guilt statements. Number 50. If a client has memory gaps after abuse, that's repression, unconscious blocking of trauma. Suppression is when forgetting is deliberate. Displacement is redirecting feelings, and denial is rejecting reality. Number 51. Rationalization is a defense mechanism where someone justifies behavior to make it sound acceptable. For example, if someone breaks chairs in anger and says, "Well, they were old chairs anyway," that's rationalization. Remorse is guilt, repression is forgetting unconsciously, and displacement is redirecting anger onto something safer. Number 52. If a client on a psychiatric unit suddenly changes behavior, your first step is assessment. Look carefully at the current medication list for side effects. Only after you've ruled out medical and medication causes should you move to other explanations. Don't rush to stop harmless self-soothing behaviors by force, and don't call family before you've assessed. Number 53. Clients have different rights depending on whether they are admitted voluntarily or involuntarily. If a client asks to leave, check the chart to confirm their status. A voluntary client may request discharge, and then you notify the provider. Involuntary clients have different legal requirements. Number 54. Family support groups need to match the situation. For families of someone with alcohol use disorder, the right referral is Al-Anon. Narcotics Anonymous is for the person using opioids, and other disease-specific or mental health family groups are for different issues. Number 55. Teaching child abduction prevention starts with practical strategies. Families can use a secret code word, and children should never approach or help an unknown adult. Recognizing faces isn't reliable. Number 56. When a client presents with acute anxiety in clinic, maybe hyperventilating, trembling, unable to focus, your priority is to stay with them and create a calm, safe space. Medications can come later if needed, but first you lower arousal and prevent panic from escalating. Number 57. With obsessive-compulsive disorder, the early inpatient goal isn't to stop rituals suddenly. After trust is built, you work with the client on a written, gradual reduction plan. Family involvement comes later, but step one is rapport and a plan that feels safe. Number 58. In dissociative identity disorder, alternate personalities are often aware of the host, but the host may not be aware of all the alters. That asymmetry matters in planning care, so you must anticipate it. Number 59. When bipolar aggression starts escalating, set immediate, clear limits with stated consequences. Don't shout or argue, and don't jump to restraints unless there's imminent danger. Boundaries keep everyone safe. Number 60. Activity choices in acute mania should help burn energy but avoid competition. Aerobics, pacing, or solitary physical tasks are helpful. Don't assign competitive or complex tasks that frustrate and overstimulate. Number 61. If a client with schizophrenia is catatonic or stuporous, offer short, calm, one-to-one presence to build trust. Then gradually progress to small groups. Isolation in a dark room is not therapeutic. Number 62. If a client hears command hallucinations, like voices saying, "Come home," always assess suicide risk directly. Do not argue with the hallucination. Safety and grounding come first. Number 63. Paranoid thinking means fixed suspicion and mistrust. Depression is about sadness and hopelessness. Hallucinations are sensory perceptions without external stimuli. Delusions are fixed false beliefs that can show up across diagnoses. Number 64. Aphasia means loss of the ability to understand or express language. Agnosia is when a person can't recognize familiar people or objects. Amnesia is memory loss. Apraxia is when someone can't plan movements even though their motor function is intact. Number 65. In anorexia nervosa, the first inpatient priority is trust. You don't start with contracts or nutrition rules until the therapeutic relationship is established. Without trust, clients won't engage in care. Number 66. The clients most at risk for alcohol withdrawal are those with chronic, heavy daily use and tolerance. A single binge is more likely to cause poisoning. Combining alcohol with sedatives risks respiratory depression. Number 67. Alcohol withdrawal delirium, or delirium tremens, has the highest risk window between 48 and 72 hours after the last drink. This complication can be fatal, so close monitoring is essential. Number 68. Disulfiram, or antabuse, education is specific. No alcohol during therapy and for up to 14 days after the last dose. Hidden alcohol sources, cough syrups, sauces, mouthwash, aftershaves, can trigger dangerous reactions. Number 69. Opioid intoxication is recognizable. Constricted pupils, drowsiness, slurred speech, and memory problems. The most urgent danger is respiratory depression. Slow breathing, such as 10 breaths per minute, is life-threatening. Number 70. If a nurse is impaired on duty, your job is to protect patients. Notify the nursing supervisor immediately so replacement staff and drug testing can be arranged. Don't cover for them. Don't confront alone, and don't just take their keys. Number 71. If a client reports a suicide plan, the priority is continuous one-to-one observation. Then you gather details about the plan's lethality and remove any means. Number 72. During a sudden loss of control in a common area, the first step is to move other clients and hazards away. Then speak calmly, acknowledge feelings, and keep your tone steady. Only escalate to restraints or security if there's ongoing danger. Number 73. Grief responses are normal, and the therapeutic response is validation. What you're feeling is part of grieving. Don't promise quick resolution, don't impose stages, and don't rush acceptance. Number 74. Crises come in three main types. Situational crises are unexpected events like illness or job loss. Adventitious crises are disasters or violent events such as floods or war. Maturational crises are life transitions like marriage or having a baby. Number 75. Dissociative disorders often involve disrupted identity or memory. Signs include sleepwalking, amnesia about personal details, and multiple personalities. Recurrent intrusive thoughts point instead to OCD, and plain anxiety alone doesn't define dissociation. Number 76. When you're educating families about schizophrenia, stress 3 points: strict medication adherence, recognizing early signs of relapse, and understanding that families may grieve chronically as the illness progresses. Education and support help everyone cope. Number 77. For electroconvulsive therapy, or ECT, safety equipment must be ready before treatment starts. That means oxygen, suction setup, and a crash cart nearby. Preparedness is non-negotiable. Number 78. Oxazepam is a benzodiazepine used for short-term anxiety. Teach clients never to mix it with alcohol or other depressants, and caution them about driving or operating machinery. Take it in the evening for sedation, and taper instead of stopping suddenly. Number 79. Therapeutic communication has some staple techniques: restating, reflecting, and clarifying. For example, "Am I hearing you say?" or "Help me understand what you're feeling today." Avoid why questions, because they come across as judgmental. Number 80. When a client complains of insomnia, validate what you observe. "I've seen you up early." Clarify what trouble sleeping means for them. Don't ask yes or no questions. Don't jump straight to meds, and don't get confrontational. Number 81. Discharge planning after a behavioral health stay should include referral to outpatient therapy, a review of progress made in the hospital, and an evaluation of whether treatment outcomes were met. Number 82. Confidentiality in therapy means you never promise secrecy. Instead, invite the client to share what feels important and explain that sometimes you'll need to share information with the care team for safety. Number 83. HIPAA rules mean you don't confirm or deny anything to curious colleagues or friends. If they ask about a client, redirect them to contact that person directly and never pass messages that reveal inpatient status. Number 84. In the first session with survivors of abuse, don't expect deep disclosure right away. Most people stick to surface-level facts about work, family, or community. Trust takes time, so support simple introductions and let the process unfold. Number 85. Peer support groups are tailored by experience. Alcoholics Anonymous is for alcohol dependence. Codependents Anonymous is for those stuck in unhealthy relationships. Gamblers Anonymous, Overeaters Anonymous, and Debtors Anonymous all work on the same principle: shared experience and mutual accountability. Number 86. When anxiety rises on the unit, the first steps are to stay with the client. Move to a quieter space and keep your tone calm and reassuring. Your presence alone can reduce the escalation. Number 87. During heightened anxiety, explore triggers. What was happening before you started feeling this way? Review recent events and invite here and now thoughts. Avoid overstimulating group tasks. Solitaire by itself is not therapeutic. Number 88. When you suspect physical abuse, ask directly but calmly, "Is anyone hurting you?" Or, "What happens when you and your partner disagree?" Stay non-judgmental and give the client space to answer. Number 89. If a client chooses to remain with an abusive partner, you are still required to report suspected abuse. Provide hotline numbers, community resources, and help create a safety plan. Never blame the victim or assume substance abuse explains it. Number 90. If you suspect an infant abduction attempt in clinic, act fast. Have a coworker alert authorities immediately while you remain with the parent and baby. Continue routine care, but never confront the suspect or offer false reassurance. Number 91. On a secure maternal-infant unit, safety design matters. The nurse's station should see every exit. Use infant security bands, cameras on all access points, and locked electronic doors. Only approved adults with matching ID bands should take a baby out. Number 92. Teach parents how to protect children from abduction. Encourage a buddy system, establish a family code word, and remind kids never to accept rides from strangers or even unapproved relatives. If separated in a store, go to an employee, not a random person. Number 93. If a 6-year-old is underweight, poorly clothed, and rocking, assess thoroughly. Measure height and weight, check vitals, and look for injuries. Talk to the child privately about school. Stay present during the exam and report neglect or abuse as required. Number 94. For an elder at risk of neglect, compare current weight with past records. Ask about food access and identify support systems. Don't offer false reassurance. Involve social services for financial or resource help. Number 95. Marital sexual assault is still sexual assault. Move the client to a private room, contact a sane nurse for forensic exam, and allow a chosen support person if the client requests. Respect and safety come first. Number 96. Assessing PTSD means looking for anxiety and hyperarousal, nightmares, flashbacks, hypervigilance, detachment, guilt, and poor concentration. Screen broadly and sensitively. Number 97. In groups for veterans with trauma, speak calmly and non-judgmentally. Deeper exploration of traumatic events comes gradually. Encourage discussion of survival and loss, and involve family support when appropriate. Number 98. If you see obsessive rituals on the unit, acknowledge them without shaming. I see you stepping in and out. Ask what thoughts come before the ritual, provide portable high-calorie snacks, and invite them to talk in a quieter space. Never order them to stop abruptly. Number 99. When caring for someone with acute mania, assign a private room to reduce stimulation. Redirect their energy into simple, productive work like sweeping. Provide high-calorie, handheld food and fluids. Avoid games or crafts that frustrate or overstimulate. Number 100. Signs of mania include irritability, rapid anger, flight of ideas, pressured speech, flamboyant dress, little sleep, and decreased appetite. Number 101. When caring for a client in a depressive phase, always begin with safety. Ask directly about suicidal thoughts. Then build the day with simple, purposeful tasks like filling small cups with birdseed. Encourage frequent rest because fatigue is common. Stay present during hygiene and mouth care to prompt and support. Avoid competitive games or strenuous activities. Number 102. Clients with depression often struggle with appetite. The best approach is small, frequent meals that are high in calories and protein. Offer things like celery with peanut butter, trail mix, or Greek yogurt with berries and granola. Avoid candy bars, which are mostly empty calories, and plain dry cereal, which lacks protein. Number 103. When responding to grandiose or religious delusions, explore what the client sees and feels in the moment. Please describe what you're seeing right now, or tell me what you're feeling. Gently present reality without arguing. You see yourself as the savior. I see you as my client. Number 104. Caring for a paranoid client begins with safety. Assess suicide risk and provide continuity of care with the same nurse whenever possible. Maintain a calm environment and avoid whispering or sudden movements. Limit physical touch. Even well-intentioned contact can escalate suspicion. Number 105. In paranoia, expect to find suspiciousness, mistrust, and rigid, argumentative thinking. Clients may be aloof, controlling, and critical of others. These patterns are consistent with the diagnosis. Number 106. When caring for someone with an erratic personality disorder, signs of improvement include no current self-harm wish, fewer manipulative behaviors, and less attention-seeking. These are measurable progress points. Number 107. Dementia is often revealed by short-term memory loss, like not recalling breakfast just 30 minutes ago. Poor judgment, such as thinking it's fine to drive without a license, is also typical. This isn't explained by taste changes or splitting behaviors. Dementia steadily erodes independence. Number 108. For Alzheimer's care, promote function with environmental cues like photos on the door and consistent routines such as a daily walk at the same time. Allow the client to attempt tasks at their own pace. Avoid isolating them in dark, unstimulating settings. Number 109. In advanced Alzheimer's, families should expect loss of walking and feeding ability, bowel and bladder incontinence, diminished awareness, and increasing need for total assistance. Infections become more common as the disease progresses. Number 110. Clients who wander need secured exits and clear, safe pathways. Walking with them is often better than trying to restrain. Time reminders rarely help at night. Number 111. When communicating with Alzheimer's clients, maintain eye contact and use a calm, steady tone. Address them by name and identify yourself each time. Give single-step directions. Avoid shouting, repeating the same phrases, or overloading with instructions. Number 1 and 12. Orientation aids for clients with altered thought processes include familiar items from home, a calendar in clear view, a bedside clock, and consistent routines. Always use their correct name, not nicknames, to reduce confusion. Number 113. When de-escalating agitation in stage 3 Alzheimer's, move slowly, approach from the front, and speak calmly. Reassure and reduce stimulation, and stay with the client until they settle. Number 114. For depression, activity planning should gently encourage social engagement. A short walk with staff, a low-intensity group exercise, or preparing a simple snack with one peer are all appropriate. Don't assign isolative or purely passive activities as the only plan. Number 115. Overeaters Anonymous clients usually binge without purging. They often eat in secret, feel helpless, and are aware their pattern is abnormal. Depression after episodes is common. Number 116. Anorexia nervosa shows outward signs like constipation, gum deterioration, dry scaly skin, lanugo, and low vital signs. These are the physical red flags to watch for. Number 117. In anorexia treatment, contracts should include measurable goals, limiting further weight loss, capping exercise time, requiring a balanced meal selection, and eating at least half of each meal. Liking food is not a measurable outcome. Number 118. For heavy daily alcohol use, assessment mirrors the CAGE tool. Ask about cutting down, being annoyed by criticism, feeling guilty about drinking, and using eye-openers in the morning. These questions quickly screen for risk. Number 119. At a blood alcohol level of 0.14, the right questions are: how much, what type, how long, and when was the last drink? Avoid shaming comments like, "What were you thinking?" and avoid trivia about legal limits. Focus on clinical safety. Number 120. Alcohol withdrawal signs include anxiety, irritability, tremors, tachycardia, hypertension, hyperalertness, insomnia, and exaggerated startle response. Seizures can begin within 7 to 48 hours, so stay alert. Number 121. With desulfiram, or antabuse, safety means avoiding hidden alcohol sources. Mouthwashes, aftershaves, and many cough syrups can all trigger a dangerous reaction. Always read labels carefully. Number 122. If a coworker seems impaired by CNS depressants, you'll see drowsiness, unsteady gait, and slurred speech. Protect patients by notifying the supervisor immediately and document what you observe objectively. Number 123. After a violent incident requiring restraints or seclusion, the first hour matters most. Meet the client's physical needs like fluids and toileting, get a timely provider order, and document behaviors and interventions objectively. Protect privacy and avoid gossip. Number 124. Signs a child may be bullied include low self-esteem, depression, tearfulness, and withdrawal from peers. Retaliation is less common, and clumsiness isn't a hallmark. Number 125. Helping a grieving 6-year-old after a grandparent's death means encouraging play and enjoyable activities, offering creative outlets like drawing, and giving plenty of physical comfort such as holding and cuddling. Answer questions simply and honestly. A referral isn't always needed if coping is normal for their age. Number 126. Neuroleptic malignant syndrome is a life-threatening emergency reaction to antipsychotics. The classic signs are very high fever, severe muscle rigidity, sweating, unstable blood pressure, fast breathing, and even excessive drooling. If you see this, stop the medication right away, notify the provider, and prepare for ICU-level supportive care. Number 127. Tardive dyskinesia develops after long-term antipsychotic use. It shows up as involuntary movements like lip smacking, tongue thrusting, grimacing, or jerky limb motions. The condition is often irreversible, so prevention matters. Keep the dose as low as possible and use regular monitoring tools like the AIMS exam. Number 128. Akathisia is a side effect where clients feel an inner restlessness. They can't stop moving, pacing, or shifting. It's often mistaken for anxiety or agitation. The best treatments are beta blockers, benzodiazepines, or anti-Parkinsonian medications. Number 129. Phobic disorders are marked by intense, irrational fears of specific objects or situations. The most effective treatment is systematic desensitization, gradually exposing the person to the fear trigger while pairing it with relaxation training. Number 130. Milieu therapy uses the environment itself as a form of treatment. That means creating a safe, structured space with clear limits, predictable routines, and supportive group activities. The goal is to teach adaptive coping and social skills within the daily routine. Number 131. Cognitive behavioral therapy, or CBT, is structured counseling that challenges distorted thinking patterns. It helps clients reframe negative thoughts into more balanced, realistic ones. It's especially effective for depression, anxiety, and OCD. Number 132. Crisis intervention is short-term and highly focused, usually lasting no more than 6 weeks. The emphasis is immediate safety, stabilization, and problem-solving, with the goal of returning the client to their pre-crisis level of functioning. Number 133. Assessing role relationship patterns means looking at how a client sees themselves, the roles they hold, and the way they interact with others. Often, maladaptive patterns in these areas contribute to mental health symptoms. Number 134. Psychiatric nursing always comes back to 5 core interventions. Number 1. Ensure safety. Number 2. Set limits on unsafe or inappropriate behavior. Number 3. Establish a trusting relationship. Number 4. Administer and monitor medications. And number 5. Always aim for the least restrictive environment. Number 135. Obsessions are intrusive, unwanted thoughts that create anxiety. Compulsions are the repetitive actions a person uses to reduce that anxiety. Think of someone who can't stop checking locks. The thought is the obsession. The action is the compulsion. Number 136. Nursing responses differ for hallucinations and delusions. With hallucinations, gently redirect the client toward reality-based activity. Let's walk to the day room together. With delusions, don't argue. Instead, distract or shift focus towards something neutral. Number 137. Alzheimer's disease is the most common form of dementia, accounting for more than 60% of cases. It's progressive and degenerative, leading to memory loss, impaired judgment, personality changes, and eventually a loss of functional independence. Number 138. Factitious disorders include Munchausen syndrome, where someone fakes or induces illness in themselves, and Munchausen by proxy, where a caregiver fabricates or causes illness in another person, often a child, to gain attention. Number 139. Psychotropic medications come with distinct considerations. SSRIs like sertraline may cause restlessness, insomnia, and dry mouth. Clozapine carries serious risks, agranulocytosis, tachycardia, and seizures. That's why frequent CBC monitoring is mandatory. Number 140. Finally, some special considerations. In anorexia nervosa, amenorrhea increases the risk for osteoporosis. In depression, safety is always the first priority before nutrition. And remember that depression often brings somatic symptoms such as psychomotor slowing, GI complaints, and diffuse body pain.